silence your phones so that we don't interrupt the session, please. And our next speaker will be Dr. Justin Lee from Florida State University, Sarasota, talking about technical guidelines for conventional TACE. Thank you.
All right, thank you so much for having me here. It's a great opportunity. So I was given kind of a big topic, which is conventional TACE. And I think there's a great opportunity to discuss conventional TACE because in the United States, at least, I think it's having a little bit of a renaissance. But if you stick around, I'm going to be doing another talk on conventional TACE. So I kind of broke it up, and this is going to be more background stuff, and then the second talk will talk about more specific things. These are my disclosures. So hopefully what I'm going to do is skip all of the background because we just had an excellent lecture about it and get right to the meat. But basically where I want to go is to review how we got to where we are right now and how TACE got into the AASLD, EASL, and NCCN guidelines. So I'm going to skip this stuff. This is from a great review article on HCC. It's, by today's standards old, 2011 New England Journal of Medicine, but I really like this map. What I think is interesting about it is that if you were to look at the colors here, Egypt sits at, the not dark purple, but pretty dark purple, so a high incidence of hepatitis infection. And the United States is actually gaining on it. If you travel through Atlanta at all, you'll see posters up that say, if you are a baby boomer, you have a 5 times increased risk of hepatitis C. So it's definitely something that's on the rise. And this graph just goes to show that. We went through the staging. The reason that we don't use TNM and some of the other staging systems that we would use for normal oncology is because it doesn't take into account the liver dysfunction, which is what we just kind of talked about in the first lecture. So that's why we all use BCLC. In my practice, I think it's still good to incorporate the Child-Pugh score. I don't really use the ACUDA score. The ACUDA is kind of a more rudimentary Child-Pugh with a little bit about tumor in it. But that gets you to BCLCC, and or BCLC score. You'll probably see this diagram in some permutation multiple times over the next 3 days here. I like this one just because it has a lot of other dashed dotted lines and really expands particularly on the middle portion being our BCLCB patients, which have a tendency to have more of a heterogeneous distribution. They either have smaller disease burdens, worse liver function, better liver function, more disease burden, somewhere in between. And I think it goes to show all the different things that we currently have to offer, including radioembolization, which is kind of a new kid on the block, so to speak, for HCC. But we're going to kind of talk about this area first. What's the reason that we have to have therapies? It's because, as was alluded to in our BCLCA patients, a lot of them, their curative treatment is to go on to transplant. Resection is still practiced, but unfortunately for patients, if your Child-Pugh score is anything above an A, and really even an A, your operative risk goes up extremely high. And this is just for all types of abdominal operations, but typically a patient who may be a BCLCB that we see in our clinic, if they're going to be receiving even something as small as a segmentectomy or a portion of the right lobe removal, they're looking at up to a 30% operative mortality, which is pretty high. This has been shown over and over again in the surgical literature, although despite this, surgery is still considered the gold standard. What if we move over here, where really you're no longer a surgical candidate? This is where the interventional radiologists in the room really blossom. I mean, I think we've got so many different things in here: chemoembolization, radiofrequency ablation, percutaneous ethanol injection, and then the combination of all the two. And I would even argue now that radioembolization, which is over on the side underneath, sort of the C side of patients, is going more towards the intermediate side as well. What's our physiologic basis? All the interventional radiologists here know, but we've got a dual blood supply, portal vein and hepatic artery, the artery being the dominant supply to the tumors, and the portal vein being the dominant supply to the liver. Of course, the tumors then end up looking like this angiographic picture off to your left, which shows their tumor blush.